Morning, friends, and it's nice to be back in Amritsar again. So enhanced intraocular lenses.
खाली जा ना, खाली जा.
Yeah, I am. So of course I have no financial interest because I've always been in the government for 31 years and whatever financial interest we had was for the patients. So we have various lenses and we started with monofocal lenses, anterior chamber IOLs, whatnot. But in the last few years, there has been an explosion of different type of lenses. Cataract surgery is refractive surgery today. The patient expectations, our own expectations. So everybody wants, perfect vision. And of course, why not? It's our aim also to give the patient the best vision possible. So, monofocal, bifocal, trifocal, refractive IOLs, diffractive IOLs, EDOF. So there's always a confusion as to what we want. So what is enhanced focus intraocular lenses? It is an extended depth of focus lenses which create a single elongated focal point rather than several foci to enhance the depth of focus. So what is important is sometimes, the patient is 6 by 6, but the patient is never happy. So you feel a patient is 6 by 6 and still the patient is complaining. So there are many aspects of vision, the contrast, sensitivity, the depth of focus. We are trying to mimic normal vision which nature has created. And so we have to understand if the patient complains, what are his complaints and how we can best provide, maybe not in that patient, but in the other patient, learning from the first patient. So this is how a EDOF lens works. Now, the topic of debate always remains whether you want to do an advanced monofocal or an EDOF lens. So, we have worked with so many lenses and it is a personal experience, okay? So what are the types? The types would be something which is dealing with the spherical aberration and the pinhole effect, diffractive lenses, refractive lenses, and diffractive refractive lenses, okay? So, these are the various lenses which deal with spherical aberration, so which is Minivel ready and Technics enhance. The pinhole effect will be IC8, the extra focus pinhole implant. Then the diffractive is the Technic Symphony and at Lara 29 MP. There are lots of refractive lenses as you can read over here. And Synergy and Eden are also diffractive refractive lenses. Okay? And you have an anterior surface modification in the Vivity lenses. Now, we have not yet published data, but we have done various eyes with Vivity, Magnificent, Eyehance, Swiss Phobe, and AdTech lenses. So, uncorrected 6 by 6 in Vivity is 60%, Magnificent EDOF is 68, in Eyehance is 36, in Swiss Phobe is 40, and in Aditech is 23. And near vision, if you see, is in the same population, if you can see. So this is the near vision, uncorrected n by 6. Now what is the target refraction, So when you are doing the target refraction, you want that the dominant eye will be corrected for distance, okay, and the near dominant eye will be 0.5 diopters. But we had a patient whom we put an EDOF, and he's a glaucoma patient, and one eye is minus 0.5. The second eye was not operated. We were operating him more because of the severe angle closure glaucoma. So when the first eye was operated, he said, I'm seeing 6 by 6 with the distance eye, and the eye, I'm seeing 6 by 12. Then when we operated the second eye, he said, make my second eye the same. But I knew he would be unhappy because I wanted a distance 6 by 6 with one eye and near minus 0.5. So we got that. When we operated the second eye, he was distance 6 by 6. But he kept telling me, Ki the first I know when the vision will improve. So it's very difficult to explain to patients if you are trying to do it. So you have to explain to them that this is the best, that binocularly you are 6/6 and n by 6 you don't need reading glasses. So all this has to be explained to the patient and the patient should be willing to do this. So here our target will be emetropia and with the same. And one more thing is that you have to be very careful. So as you can see over here, This is with plus 22 minus 0.41, so accordingly you can manage. And this eye would be 21.5. So you have to match it in this way, and this is exactly what we try to do. Good morning, sir. Good morning. So these patients, like see if you have monofocal patients, they need a more near rad. And these patients are more comfortable with an addition of 1 or 1.5 for near. In fact, not only that, all the patients who did not use reading glasses, and the brain got used to, they told me that you have to wait till the brain starts using the central segment of the EDOF lenses. Most patients were N8. And I motivated them to use reading glasses as little as possible to keep the spectacle independence more and more. One patient was +2 for distance and +3 for near. She was fasting and she got frustrated. She started using her old glasses. So post-op, she was N8, but she started reading with +5 unknowingly, and she was very happy because it was magnified. And then she wouldn't read even N36. So that's how the brain works. So you have to play with the brain when you're using these lenses. You have to convince the patient that we are not aiming at spectacle free, we are aiming at spectacle independence. So standard multifocal versus enhanced multifocal, what are the key differences, okay? So it is a aspheric monofocal, and enhanced monofocal it is a same with a higher order profile. Now, what is our goal? Our goal in monofocal is to have sharp, distant visions, especially for one eye. And if the patient understands, then you can do monovision. But when you're doing monofocal, you want sharp distance vision. That is your primary goal. And what you want to do with an enhanced monofocal is that you maintain the distance and you boost the intermediate distance, okay? Now the defocus curve will be a narrow peak at 0 diopters, and in the other one it will be a border plateau from 0.5 minus to minus 1.5. So there will be low halos in a monofocal, and there will be a similar contrast here also. It will be closer to monofocal. So the people who are complaining of glare and halos, or who do not want that, or who are driving, will be very happy. So it's the same platform. Right? So these are the points which I've already discussed. So what is the advantage? The advantage will be intermediate vision, which is not there with the monofocal. So the patient will have a meaningful boost of typical screen and desktop distances. In today's day, this is extremely important because everybody is working that way. It is useful for daily tasks, computer use, dashboard viewing. For me, I'm a myope, say -3. I'm used to reading in the morning, doing all my work in the morning without glasses. So it's important. Yeah. For me to see near very well. So there will be some near help, like I said. There will be some gains at 40 centimeters. May reduce the add power. So the most important thing is that your addition power will be very, very low. You can do most of your work at near distances. You will need for micro vision. Mini monovision strategies also can enhance effect with counseling. The third advantage, it will be a monofocal-like quality, low halos and glare. Contrast performance is very similar to monofocal. Astigmatism tolerance, it will be tolerable with less cylinders, and here also it can be preferred to standard monofocal in low cylinders. So all this will work only in low cylinders. So what are the adverse effects is that there will be a slight less best corrected distant visual acuity compared to monofocal, but you can counsel the patient. 6-12 in day-to-day life should not be a problem, depends on the profession. Increase internal HOAs, negative assay at small pupils in some measures. As with IOL, any IOL, there will be a risk of PCO, CME and all. It will be procedure related and not IOL related. So you have, as with any premium IOLs or IOLs where you want enhanced effect, you have to be careful with irregular corneas, unrealistic expectations, very high demand for maximum distant acuity. This goes for every lens, even a monofocal. So effect on the contrast, it is very comparable to monofocal sensitivity. They show a better or equal contrast with enhanced IOLs and expect monofocal-like contrast. What is the depth of focus? So enhanced depth of focus is there in one study, and interpretation is that it will be small but a tangible effect. What are the surgical or optical considerations? So centration and low tilt, decentration associated with optical performance, targeting slight myopia in the non-dominant eye. So this is exactly what I'm doing, and I think it is really benefiting. But the patient should understand that we are putting the lenses, and it's not that we've got a bad result in the eye. So this counseling is very, very important. Pupil size effects tends to be small clinically, but optics show changes more than 3 millimeter. So very small pupils, no, in any sort of lenses, there will be a pinhole effect. So one has to be careful with, very small pupils or something like that. So whenever you are doing lots of parameters for choosing any IOL now, starting from the pupil size, the corneal topography, the dry eyes, the posterior segment, so all these workups are necessary. So what is the future direction? We are going every day, we are changing. Every day the companies are coming with enhanced lenses, that this is better in my lens, that is better in my lens. So refinements in wavefront shaping to widen the distance without contrast loss. Hybrid strategies, more data will be valuable. So what are the take-home messages? Enhanced IOLs extend usable vision at intermediate and some near with monofocal-like quality. Great choice for low cylinders and very reasonable in glaucoma when tailored to patient needs. Expect tiny distance trade-offs, which the patient should be explained, and you have to explain to the patient. And as in every lens in today, I think we take more time in counseling patients than in operating. So this has become our life today, and we must deal with it, and we must be careful about it. So thank you, and I'm sorry that I overran my time.
Ragini, your next talk you want to do now?
Whatever you say, sir.
You can do so that. So the next talk of the Dr. Ragini is just some phaco cases, happenings in phaco.
Thank you, sir. So these are some videos of phacoemulsification cases. As you can see over here, this is a hard cataract, and dye-stained rexes is a must because there is no contrast. Here you have to use a lot of viscoelastic, and you have to be careful while doing the hydro. I wish Dr. Rohit sir will be showing his hard cataract technique, which is wonderful. So this is a straight chop, as you can see over here. For this, your tip has to be embedded, and you have to rotate the nucleus and then chop the other part again. These are the posterior interdigitating leathery fibers which must separate in a hard cataract, otherwise you are in trouble. So a complete division. Here you use the chopper to help you chop this piece. Again, the posterior interdigitating leathery fibers. Since the cataract is so bulky, you are not going to do a standard stop and chop, but multiple pieces. Now, once this piece has been aspirated, there is space created so that you are comfortable and emulsifying these pieces. One has to note that you have to remain in the center and let the pieces come to you, which is called as the followability of a particular machine, which has to be very good. The ability of the phaco to suck the pieces to itself, as you can see over here. The tip is very much central, and the phaco pieces are getting attracted to the tip, and once there is occlusion, there is phacoemulsification to remain for 1 second in the eye before withdrawing. So the take-home message is that brown cataracts have posterior interdigitating fibers, and these leathery fibers, breaking them in a complete division is really important. So this is the case 2, which is a subluxated cataract, as you can see. Yeah, thank you, sir. So as you can see, this is a subluxated cataract. Doing the rexes here is very important. One, you can use a Utratas, but here comfortably a rexes has been done. Now putting a CTR, you can put it at this time or you can put it after phaco, but when you put it here, what it does, it is stabilizes the bag, and you can safely put it into the bag, as you can see over here. Once the the CTR ring has been put, you can see the expansion of the bag. A careful hydro procedure is very, very important with limited amount of fluid. And now the phacoemulsification has started, as you can see. One has to be careful with the parameters that you are not pushing the nucleus and the bag is unstable. So here again you are using iris hooks. Actually capsular hooks should be used. These capsular hooks also enhance the stability of the bag with the CTR ring. So first we were using only the CTR ring, but this also helps. And as you can see, the bag is now more stable than it was before. And then you are comfortably doing a phacoemulsification. So 4 1.1 incisions are made and you have to put in a the iris hooks. It's very easy to practice on both sides also, and you can learn how to put the iris hooks. And one is comfortable now doing the phacoemulsification. And as I said, that the power has to be lowered because the bag is unstable and you don't want any fluid escaping from the zonular dialysis into the vitreous and cause more problems. So one has to be careful with the phacoparameters over here. As you can see over here, we are using the AC maintainer. We do the manual AC maintainer and the Dr. Lahane single port aspiration cannula. As you can see, the capsule, the hooks are in the capsule. So the take home message is that the capsule has to be stabilized. You need triamcinolone to check for vitreous stance. And if at all there is a problem, you can do secondary IOL also. And rhexis should be centered on the lens. So this is a third case, which is a Morgagnonian cataract, as you can see. The nick should not be in the center, but into the mid-periphery. Escape of all the fluid is important. Here you cannot do a rhexis with the needle or the Utratas forceps because this is extremely calcified. Micro scissors from Epsilon, I have no financial interest, are very, very good in this case. And you fashion a sort of a rhexis. Now here the nucleus has no support. The bag is intact. There is no vitreous, but as you can see, there is no epinuclear buttress. So the best thing would be to use a lot of visco, bring the nucleus supra-iris plane, that is to protect the endothelium, do a IOL scaffold, which Amar Agarwal sir has taught us, and that protects the PC, and then you can do a safe phacoemulsification. This is the only option, or to close this tunnel, make a 12 o'clock SICS tunnel and to remove it if one is not confident of doing the phaco. So for me, yesterday I was talking when we were discussing that in this case I would have started with SICS if I'm not confident, but the scaffold really, really works. And now you are safe with the IOL behind and in the bag so that there will be no vitreous and phacoemulsification can be done. The nucleus, though it is very small, it is very, very hard, and one must be careful. You are avoiding a vitreous prolapse or PC tear, but at the same time, you cannot damage the endothelium because the endothelium cannot be replaced. So while doing supra-iris phacos, one must be extremely careful to see that you are not damaging the corneal endothelium also. So this is really a safe technique, and nothing extra needs to be learned to put in the IOL scaffold. So that would be very easy for us to do a phacoemulsification. So that way it really helps us. And as you can see over here, one is happy with this. So the take-home message is that rhexis is difficult. You have to have all instruments as standby, and there is no support for the nucleus. So SICS I would have done in this patient. This is Dr. Lahane sir's video, and scaffold is extremely helpful in this patient. So this is the last patient where you can see that the staining of the capsule is necessary, and while staining one has to wait for 20 seconds and not really hurry. This is a hard cataract, so as you can see that you have to remain within the zone of safety. Your ultrasound power has to be very, very good for a direct chop, and it's still okay to do a stop and chop and not a direct chop. But this reduces the amount of ultrasound energy that you use and hence protects the endothelium. So that is extremely good. And as you can see, these are the stop and chop things that the phaco that you are doing here now, and making multiple pieces. Multiple pieces because each piece is very big because it's a hard cataract, and then you can take each piece and emulsify it. One must be careful to see that the sharp edges of the pieces are not directed posteriorly. Otherwise, if you have an unstable chamber, then they would tear the PC. As you can see, the rexis is slightly smaller, which helps you, but one has to create space in a smaller rexis so that there is no tear. Thank you so much. Thank you, Dr. Rohit, Om Prakash sir, and Lane sir, and Navneet, and thank you everybody for watching my presentation. Thank you so